Hey guys, and welcome. This is going to be the basic CPR AED, and then in addition to this, there'll be a basic first aid video. This is not going to certify you by watching this video, but it will certainly give you some good insights to CPR. This is actually one thing that we have set up where you can watch the videos, and then we can come in and really expedite the time that we're spending with you. So I'm going to bring up the PowerPoint for this. And we'll look, again, CPR AED basic first aid. The first thing we're going to get through is the CPR. And it's important to recognize that within those groups of CPR, we're going to deal with adults, children, as well as infants. And I put the age ranges or actual physical descriptions that one needs to be within the specific group. First of all, we have the infants up to 1 year of age. When you look at a child is 1 to the onset of puberty. So development of breast or hair on the chest, then we consider that person an adult. But the adult, anyone that does have that. So again, prepubescent child, 1 before puberty starts, that's your child range. So there's not specific ages attached to that. As we get a little further into this, it is important to recognize the chain of survival. And the chain of survival has 5 key aspects that go into that. The first is the early recognition of an event, right? So this is even something included in first aid. If that person just doesn't look okay or they're not responsive, immediately call 911. Then as we move forward, we'll make our assessment to find out if the patient's breathing. And if they're not, we're going to immediately start CPR. Rapid defibrillation is the key in this. The defibrillator is awesome primarily for adults because it only recognizes a rhythm known as ventricular fibrillation. But if you have one, we want that AED on that patient as soon as possible. The next 2 links include the effective care for ALS and BLS. That's the ambulance that shows up to take care of the patient. And then, of course, we want to transport them to the hospital, right? We can do a lot of things en route, but that best care, definitive care, is going to be achieved at the hospital. So there is some important reminders about chest compression only, right? If you don't have a barrier device or something to breathe for the patient, maybe you're going to simply end up doing the compressions. And compressions, we should recognize need to be in the right place, the right rate, the right depth, and of course the right recoil. But those are things we'll make sure we practice when we get you in class. But compression only is awesome for adults. It's not something I want to use in children or infants just because they have some different issues. But on the adult chest compressions, as we go through and we practice that, again, one hand over the other, these things can be exhausting. So just making sure you're utilizing your body in the right way to really help you instead of hinder you with these compressions. The assessment for the patient, and I have one here that can hang out in front of us. But as you approach that patient, imagine someone's down, they're not, tracking you, they're not watching you as you come up. Well, again, after I ensure that my seat is safe, say, hey man, are you okay, right? Are you okay? And if they're unresponsive or they don't respond appropriately, I'm going to tell someone, or potentially I can just take my phone and call 911. Now, from there, I need to find out if my patient's breathing. And so we simply tilt that head back, and now we're going to spend somewhere between no less than 5, no more than 10 seconds to find out if they're breathing. And if they're not, then we want to go straight into compressions. And with compressions, compression should always be done hard and fast. There's certain parameters we try and keep in mind, and I put those at the bottom of the screen for you. Minimum 2 inches in depth at the person's center of their chest. That rate is 100 to 120 times in a minute. And we also want to allow that chest to fully and completely recoil. Simply means when you press down, make sure it springs back from that point from where it started. Again, this will be, a pretty easy thing to practice once I put the mannequins in front of you. But on the compression only, notice he's kind of got those arms straight as he continues to do the compressions. Teamwork is a key to this. And after about 2 minutes of CPR, Almost anyone's going to be tired, if not exhausted. So always keep in mind, if there's an extra person with you, you want to change out that compressor every 2 minutes, if possible. When we get into the compressions and the breaths, that different barrier devices that are available, I'll show you those on the next page. But when you do breathe for someone, all you need to do is breathe in enough simply to make the chest rise. I've got actually with me an example of a face shield, or just this clear piece of plastic that actually can fold over the patient's mouth and nose that enables you to provide breaths for them. Again, this is something that has been in my keychain for many, many years, but I'm still able to get this thing out. And how I would utilize this is as I place this over the patient's nose, or I should just say their mouth, I still end up wanting to pinch the nose, but I can actually breathe into that while I'm pinching the nose, but only put enough air in to make the chest rise. And again, it's just a simple piece of plastic that is designed to have that specific one-way valve. I can't just take a piece of saran wrap and use that. Notice how it's got the hard plastic, goes over the patient's mouth, but that protects me for potentially things that can come out. But any one-person CPR is always done at 30 compressions and 2 breaths. Unless, of course, you don't have a barrier device, then you're simply doing the compression only. But only one ratio that you really have to keep track of with this basic CPR. These are some examples. This is a pocket mask. And again, those little devices, just like what I was showing you here, can be great if you actually have those. But we have to also consider an adult goes down. There's no barrier device for me. If I do compressions, call 911, potentially get an AED, we can have some really high survival rates for those patients. So again, make sure that as we're going through this, feel free to take your notes, jot something down, and that way when we go into class, we can, answer those questions right away. Again, if you don't have questions, that's fine too. But again, I want you to know there's definitely opportunity for those questions and answers before we start putting our hands on the mannequins. No, also important to recognize the difference in between adults as well as children. So adults tend to have cardiac arrest brought about by some type of cardiac arrhythmia. Children and infants, on the other hand, they tend to choke, drown, anaphylaxis, which is an allergic reaction that causes that airway to be blocked. So children and infants tend to suffer more of what's known as a secondary cardiac arrest. So that's why it's so important to breathe for those two groups, if at all possible. Again, if it's your own child, I'm not going to hesitate to breathe for them. If it's someone else's child, or let's say I was responsible for watching them, then I would definitely want to breathe for that person. Same thing goes with drownings. Drownings are secondary cardiac arrest, and breathing for those patients tends to be most beneficial as well. But those were just the key issues I gave you, and now we can see the slide for it. But children and infants issues tend to be breathing. There's not a lot of 2 or 3-year-olds out there, that suffer from arterial or atherosclerosis. That's the narrowing or the hardening of the arteries. And that happens with adults, every day. So that's why, if you're considering this, why should I breathe for the child? It's because they're different, and that would be most appropriate for them. The children or infants, as far as the amount that you're actually looking to put in, just keep in mind with a child or an infant, probably someone who's smaller than we are, we just have to breathe enough to make the chest rise. It's not a deep breath from yourself. It's just simply breathing in till you see that chest visibly rise. You release that, let that air exhale, and you do that twice. And that's where the ratio of 30 compressions and 2 breaths comes from, right? 30 compressions, hard and fast, center of the chest. When you get done with the 30th, stop. And try never to take more than 10 seconds to give those 2 breaths, because then you're actually interrupting that oxygen flow to the person's brain. For the child CPR, again, with an adult, kind of recap that's 2 hands making sure as you push down, it's a minimum of 2 inches in depth, 100 to 120 times a minute, provide that full and complete recoil, again, right in the center of the chest. For a child, they're utilizing a different technique here, right? Now it's simply one hand, but it's actually the heel of your hand because that's the strongest point of your hand. If you're a smaller individual or that's a bigger child, because remember, a child is 1 to the onset of puberty. Puberty may not happen until 12, 13 years of age. And so again, if you're smaller, that one hand, I'll do the same thing where I'll put the mannequin up here. So these are all great things that we want to practice. It could be either the one hand as you do it, but after a while you may find yourself getting tired. So that supported wrist is certainly okay. Or even using 2 hands on a child is certainly okay based on your needs in order to complete a good compression, right? There's a million ways to do a good compression. We just want you to focus on which one's going to be best for you, because that in turn will be what's best for the patient. Ratio is 30 to 2, right? 30 compressions, 2 breaths. Anytime you have a barrier device, 30 to 2 would be the encouraged way you would do CPR. But without a barrier device, remember, compression only is something we fall back to primarily on adults. Your compression landmarks and points for the actual child, we're still in the center of the chest, but here's a slight difference. Instead of a minimum of 2 inches, it's actually about 2 inches in depth that you want to compress. The rate stays the same. It's always 100 to 120 compressions in a minute. And then we still need that full recoil in the chest to take place. What that full recoil does is it actually allows the chambers of the heart to adequately fill in between compressions. So when we think about compressions and why they're so important, that's moving that oxygen supply in the patient's body up to their brain. When the AED comes in, and that stands for automated external defibrillator, that's a device that can actually shock the heart back into its normal rhythm, right? Because ventricular fibrillation needs to be defibrillated. And the device is actually called an automated external defibrillator. So they're great, they're easy to use. I look forward to walking us through that as well. But just keep in mind, ratio 30 to 2 for adult, 30 to 2 for a child, 30 to 2 for an infant. Maybe some slight variances on how we get those compressions done, dependent, of course, on your size. When we're looking at the infant here has some different techniques utilized, typically 2 fingers as you're compressing. And what's good about this picture is you should always be able to see your fingernails as you're doing your compressions. That just means as I'm compressing, notice I'm using the pads of my fingers. I'm not using the tips. I'm not placing this down where the middle finger is longer than the index finger. It's hard to get a good compression that way. So as you slide your fingers right in between the nipple line, we'll look at the parameters that come on this slide next. So we see that 2 fingers just below the nipple line, same speed, 100 to 120 compressions in a minute. Now we're pushing down about 1.5 inches or 1/3 the depth, the anterior portion of the baby's chest, and we still want to make this recoil. Again, that's what's really great about the CPR. You can think of this as just being really eye-opening, that we go minimum 2 in an adult, we go about 2 in a child, and we go about 1.5 inches for the infant. But it's always 100 to 120. Center of the chest or right below the nipple line on the infant. We always want to make sure that chest comes back or we're providing the recoil for it. So lots of similarities in our compressions. We just vary those slightly as we move through the different patient groups. 30 compressions and 2 breaths. Why I put this on here is so we just remind you that with the infant, you would actually cover the baby's mouth and nose with your mouth, right? You want to cover both of those structures. How much air is it going to take to ventilate into an infant? Not much, right? Infants are smaller, we think about comparatively to our size, so it's not going to take probably more than a second worth of air to make that chest rise, but only put enough air in to simply make the chest rise. Such a key part of all the CPR when we're breathing for them. How that may actually look is demonstrated on the slide here, where we're actually breathing for the baby. Again, always you would be encouraged to breathe for that infant and child if it is, of course, safe to do so. Now, a little bit more on the breaths just because they're important, and this is such a key part with all CPR. It's just making the chest rise. Okay, talked about that being about a second or so. In your size in comparison to their size, how much is this actually going to take? You know, I would never say it's always a second or it's half a second, right? Babies are different as well. So the infant could be anywhere from 6 to 8 pounds at birth. Now, as they're 11 or close to that 12 months of age, maybe they're 20 or 22 pounds. Yeah, that's a little larger tidal volume or the air they have in their lungs. That's why I say don't think of it for exactly that second. About gives you a good variance. But again, of course, it's safer for the infant because we're not going to put too much air in. Just make the chest rise. We haven't stressed that enough. So with all CPR, just keep in mind, keep doing this until help shows up, right? As you keep doing those compressions, that's oxygen circulating throughout the body, getting up to the brain. When we breathe for them, we're trying to replenish that little bit of oxygen that can add to their circulation. So there are certain times you can stop CPR. If you are physically and completely unable to resume, okay, it's understandable, right? If I was going on and continuing, I myself am going to need help. Okay. You can also stop when a physician orders you to do so. Or what is most common with this is that you can stop once that help arrives, right? EMS shows up, take control of the patient. Thank you very much. And we will continue on from there. So there's one more, and I hate to even talk about this because this isn't the most pleasant of things, but if there's obvious mortal injury, such as a decapitation, lividity, or rigor mortis, that's the stiffening of the body. Lividity is where the blood actually pools down when someone is deceased. So again, and we can clarify any of these topics or areas if you have questions on them, but try and keep doing this, even if it's a slower compression or you're not pressing as hard as you originally were, that is still better than nothing, right? Oxygen's getting to the brain, so it's better than nothing. With choking in adults, as well as children, this tends to be what you see, right? Someone opens their mouth, they cannot make a sound. And why I put the piece of chicken up there is because it usually happens while they're eating. But my first thing, and I would stress this for us as well, is the first thing we want to do is make sure the person is unable to speak. If the person is unable to speak, when I say, are you choking? Right. They just nod their head. Now it's time to help. The difference is for someone who is potentially coughing or, it looks like they're having a hard time breathing, it's really important what we don't do for them, right? I don't want to pat that person on the back that could dislodge the object and now they truly are choking. So again, as long as that person can speak, they're still moving air, kind of hands off. Doesn't mean you don't call 911 right away just to make sure they get that additional help because things can go wrong in a hurry, but just encourage them to cough to try and get that object out on their own. These are some examples of the hand placement. And again, this is going to be an important one to practice as well. But if they are pregnant or obese, it's actually something referred to as the chest thrust, where you're simply putting that full hand directly in their chest and just pulling straight back. That's what we want to do if you can't get your arms around someone or if they are pregnant. For the typical move here, and it's got a couple of names which are really considered interchangeable. The abdominal thrust, also referred to as a Heimlich maneuver. But with that, we want that actual thumb side of your fist placed right above the belly button as it's inward and upward motion, right? The other hand is on top to help me provide that strength so we can force that air out. Hopefully that will relieve the obstruction. But if it doesn't, then we'll look at what happens to the unconscious protocol. But we should also look at this guy first, all right? Because infants, when they are conscious, again, usually happening when they're eating, the first thing we want to do once we confirm that baby can no longer, I don't want to say speak because I don't think babies are really speaking, but they can't cough, they can't make a sound. Notice what they've done here is they place that infant in a position where the head is above the rear. right? And so as you do that, you want to make sure you find these 5 back slaps. We flip the infant over. We're completing 5 chest thrusts, and we alternate between those 2 positions until the object comes out or the baby goes unconscious. So adult and child, it was either a chest thrust, a Heimlich maneuver, or the abdominal thrust. For the infant, again, while they're conscious, we do the back slaps and the chest thrust, 5 and 5, 5 and 5. We alter that while making sure that the baby's posterior is above his head, then as we flip him over. But again, another great opportunity to practice the hands-on skills and make sure everybody's comfortable and confident with this. Now, if any of these patients, adult, child, or infant, does go unconscious, our steps are simple. We start CPR, and after 30 compressions, we look in the mouth, and only if you can see it do we work to remove that obstruction. So the conscious protocols, adult, child, infant, back slaps, or Heimlich maneuver, or chest thrust. But when they're unconscious, call 911 and go straight into CPR. Your biggest modification is when you get done with compressions, visualize the airway and only take something out if you can actually visualize it. You do not want to do what's referred to as a blind finger sweep. That's just potentially dangerous and can lodge that object further down into the patient's airway. Now with the AED, automated external defibrillator, I brought one of these, and we will of course have one of these on your class day, because the AED is probably the best tool that we've had in many years for CPR. It's funny, CPR itself has been around since really the early 60s, but the AEDs, these things are becoming more commonplace. There's a program called public access defibrillation. So you may have gone to the mall or in a grocery store and you see, something like this just on the wall. That's because they're safe, they're effective, and honestly, anyone can use an AED. So we'll kind of go through the protocols of who would we place an AED on. Now I would tell you, if the patient is not breathing, right, I've done my assessment, I made sure the scene is safe, I checked the patient for responsiveness, nope, they weren't responsive, I told someone to call 911, or again, maybe I did that myself. And if that person is down, you can start compressions right away. And then once this device arrives, this is what you want to use. This thing takes priority. I know we'll look at these things all work in a similar fashion. And I will tell you, the first thing we got to do is turn it on. Turn it on and follow prompts. So just as an example with that here, I turn it on.
Apply pads to patient's bare chest. Plug in pads connector next to flashing light.
So again, as we run through this in class, you should be familiar with, hey, what's the first thing I have to do to the AED? You turn it on. And the next thing was following prompts. The AEDs are all set up where the pad placement is on the pad. So again, I don't know how well you can see that, but it clearly designates that a pad goes here and then one goes down on the left side of the person's chest. There could be some concerns or really some issues that come up with the AED. I gave you an example of these two here, right? You got a hairy chest. Well, of course, not you yourself, but your patient. If they have a hairy chest, the AEDs come with razors, right? It's just a couple of swipes on that. I'm looking at, that chest over there, and that looks like a nightmare. But they are good, high-quality razors that come within the AED themselves. Again, if someone's pale, cool, and diaphoretic, or we can say they're sweaty, well, then dry them off, right? But we want to make sure the AED is placed on the bare chest, which means no bra, no hair, no moisture. There's also a set of little trauma shears that come in here where you can simply cut the person's bra so then you can expose and place the pads on their chest as well. I know just looking at the ones from the pads I gave you may have been a little difficult to actually ascertain that placement. So I wanted to put this up as well, right? But all of the pads that you have for AEDs actually do have those pictures, right? That's why you can see it goes here, it goes here. Just remember, turn it on, follow prompts, and then we hit the shock button if indicated. It will take us, again, much less time to run through this material in class since you've been kind of familiarized with this equipment and how it works. This next slide is very important as well, because we want to make sure that all questions and your comfort level is up, right? Everybody's got, potential to not be as comfortable with this versus that, or it's choking versus the compressions. You're great at compressions, but you're worried about the choking. Great, please bring those things up, and those are the things we will discuss in your class. If you don't write notes or you didn't write notes and you think about something, just drop it down in the comments section, because before we come out to all your classes, I'll again look at those just to make sure I can address any concerns that anyone may have about any of this material. Again, this is simply the basic CPR, how we use the AED. We'll combine this with that face-to-face instruction, but hopefully I was able to answer some of the questions you may have had about this, and most importantly, know that we'll have more time to answer these things as we go through this in your actual class itself. So again, thanks for taking the time to do this in advance of your class, and I look forward to meeting with you guys in person and, of course, answering any questions at that time. Thanks.